and then connect it to a manometer by which we can measure the pressure inside of the eye. That will be actually the true intraocular pressure. But cannulating in every patient is not possible at all, and although it has got risk involved with it also, and therefore we have developed this method of measuring the intraocular pressure, which is known as tonometry, and this is done with the help of instruments, and they are known as tonometer. Now, intraocular pressure is the pressure inside the globe, which is difference between the absolute intraocular pressure and atmospheric pressure at any given moment. So why is tonometry important in our scenario? Because we know in definition of
Don't worry about that line. Don't worry about that.
Hello.
Dr. Shalini, we can't hear you.
Yeah, Dr. Shalini, we are not able to hear you.
I think Dr. Shalini has been muted. We can see the mute logo on Satyajit and
is
Dr.
it all right now?
Yes.
Is it all right now?
Yes,
Can
fine.
you hear me? And
Yeah, we
can you
can
see
hear
my
you.
presentation?
No, we can't see your presentation. You can share your slides once again.
Okay. Okay. Is it all right now?
Yeah. We can't see the slides. Yeah, now we can see the slides.
Dr. Maneesh?
Yeah, madam, we can see your slides and we can hear you also.
Okay, fine. Thank you. So the question is, why is tonometry important? Now, if we see the definition of glaucoma, we know that the intraocular pressure is the most important risk factor. And that is why it is very important to measure the intraocular pressure. Intraocular pressure is the mainstay strategy of glaucoma management. In all our patients, what we do actually is reduce the intraocular pressure to control the glaucomatous optic neuropathy progression. So, moreover, if there is large fluctuation in intraocular pressure like circadian rhythm, then also there is damage of optic nerve head and glaucoma progression. Therefore, diurnal monitoring of intraocular pressure is also very important, also for management and also simultaneously for diagnosis of our patients. Now coming to principle of tonometry, of measurement of intraocular pressure by deforming the globe and then correlating that force of deformation which is responsible and measuring that deformation is the pressure which is there inside the eye. So it can be of two types. One is indentation and another one is applanation. So what does indentation means? That means we are indenting the globe. You can see in this animation that there is this is the indented spot. Now because of this indentation, the displacement of aqueous is quite a lot. And this indentation, if the globe is hard, the instrument will require more force to indent the globe. If soft eye, the instrument will require less force to indent the globe. And that is how we measure the intraocular pressure in indentation method. But because the displacement of aqueous is quite a lot in this method, that is why we resort to another method, which is applanation. Here what happens is that the surface of the cornea is flattened. It is planar surface, and therefore the aqueous displacement is very less, and that is why applanation tonometry is more accurate. So when we talk of applanation tonometry, we can have two types of applanation tonometer. One is constant force applanation tonometer, which is MACKAY tonometer, and another one is constant area tonometer, which is the Goldman applanation tonometer. So coming to first one, which is the constant force tonometer. Now here you can see in this diagram, this is a force. This is the weight which is applied onto the corneal surface. Here you can see there are multiple weights. So these weights, they are held in this wire holder, and then it is pressed onto the surface of cornea. So force is constant, right? Now applanation varies. So what we do, we measure the circle of applanation. Here you can see the circle of applanation are there, and then they are correlated with this chart, and then subsequently the reading of intraocular pressure is given. So this is constant force macular tonometer. Now coming to the gold standard tonometer, which is the Goldman Applanation Tonometer. Now here it is very important for all your PG students to learn about Goldman Applanation Tonometer. Not just theoretical part, you also need to do it very regularly, because anytime you will be needing in your vivas, in your theory, and also furthermore in future in your clinics also you will be needing Goldman Applanation Tonometry as a mandatory instrument. So this is the instrument which you all should know very well. So it is based on Imbert's fixed principle. What does that say? It states that an ideal dry thin wall sphere, which is actually our eye is not an ideal dry thin wall sphere, but it is an assumption which is made by this Imbert's fixed principle, which says that pressure inside the sphere equals the force necessary to flatten its surface divided by area of flattening. So pressure can be measured by this formula of force upon area. Now, when we see that the diameter, we know that this is a fixed area tonometer. So diameter of the external area is 3.06 millimeter. Now at this diameter, the scleral rigidity is balanced by the capillary action of the tear film, and that is why the effect of scleral rigidity is minimal at this diameter, and that is why we take this diameter. So now whatever reading we get, we multiply it with the help of 10, and that is how we directly get intraocular pressure. Now let's see this assembly of applanation tonometer. What are the various parts? First one is the housing. Now here whole of the assembly is there inside this housing, and then we have this feeler arm or the rod which is attached with this assembly, you can see, and at the top of this is the biprism. Now this biprism actually divides the circle into two semicircles, and when we stain the surface with the help of fluorescein dye and we see in cobalt blue light, then we see this kind of picture from one eyepiece of the slit lamp. So it is a uniocular examination. Now this is the adjustment rod, and here at the base of this adjustment rod, you can see the measuring scale. Now this is the knob which is rotated so that both of these semicircles we can see. So each of the semicircles meet at a point, and that point is seen here in this measuring scale, and that is multiplied by 10 to give you the reading of intraocular pressure. So we will be seeing a video also. So first of all, you need to explain the procedure to the patient. You need to instill topical anesthetic eye drop, instill fluorescein dye, and switch on the blue filter of your slit lamp. Now, after that, it is important to set the dial of your, this is the measuring scale. You need to set the dial between 1 and 2. 1, that means 10 millimeter of mercury, and 2 means 20 millimeters of mercury. So if we assume that pressure will be normal, that means it will be between 10 and 20 millimeters of mercury. So what we do, we keep the dial between 10 to 20 millimeters of mercury. Now, with that, we advance the prism towards the cornea so that it just touches the cornea. And then we will see the two semicircles, and then we try to rotate the dial so that the inner margin of both the semicircles meet. Now you can see how we rotate the dial, and so that the inner margins of the two semicircles meet. Now this is the applanation tonometer mounted on the slit lamp. Now this is a video. This is a pre-COVID era. So we are touching the eyelids, but ideally in COVID era, you should touch it with the help of buds, right? Then you put the fluorescein dye inside the eye. If there is excess fluorescein dye, always clean it with the help of cotton. Now in COVID era, you need to wear your gloves to do the procedure. Now you take the prism towards the cornea and it just touches the cornea, you don't press. Now here you can see two semicircles which are, the inner margins are not meeting. So what will you do? You will rotate the drum to the values by looking into the slit lamp so that the inner margins, they start meeting also and they start pulsating also. So once they start pulsating, that is the reading you need to record, and then you multiply it by 10. So you might see semicircles like this. You might see semicircles like this. But the ideal one is this one. So these two are not the correct semicircles. Similarly, you might see variety of these semicircles. Sometimes half might be larger circle in the inferior hemisphere. There might be a larger circle in the superior hemisphere, or it might be out of your prism, or sometimes dye would be so less that it is not visible. Sometimes the amount of dye is too much, we need to wipe it off. So all these images which you are seeing are not the ideal. And you will always get incorrect reading if you get these kind of mires. So what is ideal? This is the ideal scenario when we get adequate thickness of the circles along with proper semicircles being inside the prism which you can see. So it comes with experience. Gradually, as you start doing it regularly, you can easily identify what is right and what is wrong. So what are the advantages of Goldman Applanation tonometer? It is validity, reliability, reproducibility, and repeatability is extensively published, and that way we believe, and everywhere it is still there, that it is the gold standard technique for measuring intraocular pressure. But there are disadvantages because topical anesthesia is being used. It is a contact device. There's always a risk of infection. Amount of fluorescein dye, as just now I showed you in various pictures, amount of fluorescein dye is very, very important. Then first is attached to the slit lamp, we require a sitting posture for our patient. So if patient is in lying down posture, we are not able to do applanation. And then it is also affected by corneal thickness. We will see in our slides later on. Besides this, corneal shape might also hamper the reading, especially if you have a astigmatic cornea. And if you have a 3 to 4 diopters of astigmatism, it might actually change your intraocular pressure by 1 millimeters of mercury. So if you have an astigmatic cornea, you do have an option in Goldman Applanation tonometer. So what is that? Now, normally what you do is you match the zero axis of this your holder with the zero axis of the biprism. But if you have an astigmatism, what you do? You rotate your prism at the minus axis or the steep cornea, and then you start taking the reading, and then you see these kind of mires, the oblique mires. Then you get more accurate reading in astigmatic patients. Besides this, there are other factors like corneal thickness. If you have a thicker cornea, you will overestimate the IOP. Similarly, if you have a thinner cornea, you will underestimate the intraocular pressure. So if you have a patient who is having thick cornea and he is having a pressures of more than 20 millimeter of mercury, say 24, 26, you know that it is coming due to over thickness of the cornea, or because corneal thickness is more in that patient. So you need not to panic. It is also affected by rigidity, ocular rigidity, and then there can be calibration error. So for checking the calibration error, which should be done once in 6 months, you have a calibration rod like this. So you have 3 markings at each side. Center one is the 0 here. The second marking on both the sides corresponds to 2, and the third one corresponds to 6. So you have a slot in your slit lamp where you can fix this calibration rod, and then you can check your calibration. So if there is problem with the calibration, then you have to send your instrument to the manufacturer. You can check it, but you cannot correct it yourself. Better to send it to manufacturers. Now coming to another important tonometry, which is indentation tonometry. This was introduced by Schiotz in 1905. I would request that not to touch the screen, otherwise these lines are coming on the screens. Thank you. So the principle of indentation tonometry says that a plunger will indent the soft eye more than a hard eye, as we discussed in previous slides also. So because this displacement of volume of fluid is quite a lot, so there can be problem in measurements with Schiotz tonometry. Here it is represented by the movement of a lever. I will show you further, and is proportional to the pressure inside the eye. So let's see the various parts of Schiotz tonometer. Now we have these handles to hold the Schiotz tonometer onto the cornea. Again, it is a contact procedure, so we need to anesthetize the eye. Then we have foot plate which rests onto the corneal surface. Then we have plunger which freely moves within the shaft of the foot plate. Then we have bent lever. Now this lever actually, we can see this lever, and this is the measuring scale on which it projects. So the degree to which the plunger indents the cornea is indicated by movement of the lever. And then there are multiple weights. 5.5 gram is already a. We have extra weights of 7.5 and 10 milligram. Now, this is the conversion table. Now, once you check the reading on the measuring, you can see the corresponding intraocular pressure reading. Now, here, suppose the reading is coming to around 7 millimeters here. Then you go and check this Frenvel's nomogram and check that at corresponding reading of 7 and at 5.5 grams, what is the reading? And here you can see it is 12.2. That means the pressure is 12.2. So I'm sure that all the PTs, they are regularly doing this, both the techniques, Applanation and Schiotz, and they must be knowing it very well. So the question is that if the readings of Schiotz are not that accurate as Applanation, are there still indication of Schiotz tonometry? So let's see the advantage. Now, advantages are that it is very, very user-friendly. Second, can be used by anyone very easily. Learning curve is very small, and it is portable and affordable also. But as we said, there are problems like it is affected by scleral rigidity, by compressibility of vascular contents, and also sometimes what happens is that if pressure is too high, the cornea gets sucked in between the plunger.
Dr. Shalini? Madam, can you hear me?
Yes.
Yeah, I think we just lost your audio
Yes.
and your slides also. Can you share your slides once again?
Okay. Okay.
I think we just lost the audio and
the
slides. And I'll also request.
Okay. Am I audible now?
Yeah, you're audible. Yeah. In the meanwhile, I also request all the participants to please keep their microphone muted. We can see some of the microphones are switched on, which is causing a bit of disturbance. And Dr. Shalini, you can share your, you can enlarge the screen. Yeah. Dr. Shalini, can you hear me?
उनका आवाज नहीं आ रहा है.
I think there is some connection issue. We'll just wait for a moment. I'll talk to Dr. Shalini and get back.
Take your time. There is no hurry.
Yeah.
Nothing to panic.
Hello.
We can hear you, madam, now.
एक बार फोन से बात कर लो.
हाँ, Dr. Shalini से बात हो गया. She's reconnecting. I think there is some network issue there.
Okay,
She's just
okay.
reconnecting again.
No problem. No.
We can already see there are almost 90 participants. So in case anyone is having any questions till now, they can share on the chat screen. If any of the participants is having any question related to whatever we have discussed till now, they can share on the chat screen. Dr. Vikram is there. Dr. Satyajit and we also can try to answer your question. Till then, Dr. Shalini will join back. Do we have any questions related to whatever we have discussed till now?
There is a question.
Why we can't see our dial below 10? Why we can't set our dial below 10? So basically, sir, the question is the dial reading in GAT is between 1 and 2 or at 1. I'm not very sure what is the exact question. There is one more question, how to do Applanation tonometry in. I think this question is incomplete. So basically, we know that whenever you start doing Applanation tonometry, we generally recommend that you should start either from 10 millimeter mercury or you can start from 16 millimeter mercury, and gradually you can increase or decrease depending on the MARGs. You basically try to rotate the drum to try to meet the inner edges of the MARGs. Once the inner edges of the MARGs they meet with each other, that is the time when you check what is the reading on the measurement drum. So we can start with 10, we can start with 16, we can start with 20, but general recommendation is you can start at 10 or with 16 and gradually try to increase it. Now there is another question, how to do Applanation tonometry in corneal astigmatism cases. I think this is something which Dr. Shalini was already explaining about it, how to do check intraocular pressure in patients with high, how to explain the correction factor for Applanation tonometry and corneal astigmatism. Dr. Vikram, are you there? Dr. Vikram Jain?
Yes, Maneesh, I'm here.
Yeah, will you like to answer any of these questions? That what I think correction factor for Applanation tonometry we'll be discussing when we were discussing pachymetry.
Yes.
There are multiple correction factors available, and Dr. Vikram also will be discussing about target IOP. That time also I think he'll be highlighting about the correction factors. But anything you will like to share about any tips you do in patients with high corneal astigmatism like keratoconus or patients post penetrating keratoplasty? Anything particularly you like to suggest to our participants?
Yeah, regarding high astigmatism, Dr. Shalini had just covered before she went offline. The thing is, as she showed, there's a small mark on the holder which holds the biprism. So for high astigmatism cases, you may miss your actual pressure by around 3 to 4 millimeters because of the astigmatism. And if you rotate the prism to align with that, then you would be getting a good semicircular Myers. Otherwise, the Myers itself won't be good and semicircular. They'll be sort of stretched like how you see the placido disc itself, therefore leading to an over or underestimation.
Thank you. So this is one very important tip Dr. Jain has shared. And another thing which I've seen which can be tried is that you can do an Applanation tonometry in the normal way what you're doing, then rotate it by 90 degree, and then again in vertical axis you can try to do it and take an average of both of the readings. So that is something which you can try. There is another way what you can follow in patients with high corneal astigmatism. And there is also a question that how frequently calibrations should be done in Goldman Applanation tonometer. Now, ideally, every day morning before you start your clinic, you can do the calibration. Some people recommend that once a week at least we should check the calibration. It's a very simple procedure. It hardly takes a minute to check the calibration. You can do it with the calibration rod once a week. You can also check the calibration even without the calibration rod, just at the zero number by seeing the movement of the tip. I think Dr. Shalini is back, so I'm sure she'll be covering the calibration in detail. Madam, will you like to share your screen again?
Yeah, sure.
Yeah.
I'm sorry for the connection.
We have a lot of questions which we will take after the presentation.
Dr. Shalini, you can switch off your video. Once you have shared your screen, your presentation, you will go on and we can hear you, but you can switch off your video, then the load will be less on the bandwidth. मैम का आवाज नहीं आ रहा है.
Am I audible now?
Yes.
Yeah, you're audible. You're audible.
Okay, okay. I will close the video. You said stop the video, right?
Yeah.
Yes, yes. And you can share your screen.
Okay.
Perfect, perfect.
Okay, fine. So we were discussing about the indications of Schiotz tonometry at present scenario, and despite there are some issues with Schiotz tonometry, we do it in the patients who are uncooperative or supine positions, or sometimes if we are in camp or community outreach, then also we can do Schiotz tonometry in those patients. In fact, if we see the studies, it has been found that they agree better with Perkins tonometry than a non-contact tonometry. So Schiotz still has role in certain scenarios. Now, another important issue is that we need to reduce the risk of cross-infection, which is very, very important with both of these tonometers because they are of contact degree. So we need to avoid the tonometry in any individual which is having an infection or is having a red eye. The thing is that we need to clean the tonometer tip with the 70% isopropyl alcohol swabs, and moreover it takes care of the corona infection also, so it should be cleaned with 70% isopropyl alcohol swab. Besides this, you can put or soak your tonometer tip in 1% solution of sodium hypochlorite. Now it is important to dip the tip not beyond 10 minutes because it is corrosive and that will damage your tip. So just put it within 10 minutes. You should remove it and thoroughly clean it and let it dry, because if it does not dry, it is actually toxic for the corneal epithelium, and therefore you need to rinse the tip thoroughly. Now coming to other variable force or fixed area tonometers which are there, Goldman we already discussed. Then we have non-contact tonometers. We have handheld tonometers like Perkins and Draggers. Besides this, we have another group of tonometers which are MACKAY MARG tonometer, the pneumotonometer and tonopen, which are good for corneal disorders. So what we need to do, in non-contact tonometry, there is a rapid air pulse which actually applanates the cornea. And the intraocular pressure is estimated by detecting the force of the air jet at the instance of applanation, how much force is required to planate the cornea to other fixed area. And that is actually checked. The intraocular pressure is checked by the machine inbuilt sensor in the machine. So it is a very fast, simple and non-contact methodology, and therefore it is very commonly used for screening of patients to avoid any transmission of infection. But it is important to avoid in this area because it actually forms air droplets, micro air droplets around the machine. So in COVID era, where we need to be extra careful with this device, non-contact tonometry, and we don't use non-contact tonometry in this era of COVID. Now coming to what We don't require any fluorescence. It can be performed by paramedics also, but the take average of 3 readings, then we can confirm the readings if they are beyond the normal range. We need to confirm the readings with the Goldman Applanation Tonometry. Now, because it is more influenced by central corneal thickness than Goldman Applanation Tonometry, we need to be extra careful in the patients who are having abnormal corneal thickness. We should never start the treatment on the basis of NCT readings. Suppose you've got an NCT of 26, wait and watch and confirm your readings again with Applanation tonometry before jumping on to treatment. And then it is unreliable in patients who are non-compliant, who are having any corneal disorders in children. So there again, we cannot use non-contact tonometry. But otherwise, it is a very useful device in a busy clinic practice where you want to screen a lot of patients. Screening can be very non-contact tonometry. In fact, handheld versions are also available, but handheld non-contact tonometry are actually not that reliable. So handheld is not that recommended. Now, besides this, there are other handheld devices like Perkins tonometer. Now, the advantage with the Perkins tonometry is that it can be held in any of the posture. So suppose there is a child who is under general anesthesia, the tonometer of choice is Perkins tonometry. You can easily do Perkins in any of the child, any of the patients who are lying supine. Now, this Dragus tonometer, which has an electric motor inside and it has a different biprism, is not used nowadays. Then comes the MACKAY mark type of tonometer. Now, what is there? Now, in MACKAY mark tonometer, there is this small area. This is the area which is one plunger, which is 1.5 millimeter in diameter. And there is a rubber sleeves or silicone sleeve, which is 3 millimeter diameter. Now, there is an air pulse, which actually on a plunger floats on the air pulse in between on the surface of cornea, and we move the plunger towards the cornea so that there is the air pulse which is freely flowing. It is actually obstructed with the help of plunger, and the amount of force which is required to flatten or to disrupt that air which is floating between the plunger and the cornea, that is regarded as a measurement of intraocular pressure, and that gives a kind of tracing, continuous tracing in MACKAY mark type of tonometer. So this is pneumotonometer, which is based on the similar principle. Good thing about pneumotonometer is that it gives pulsatile ocular blood flow measurement also. But nowadays, the prototype of MACKAY mark type of tonometer is TonoPen. Now, the same principle is here in TonoPen. The advantage is that it is a handheld device, and moreover, it has got a cap on its surface which is disposable. So if you remove this cap, you will have a sheet which is there on the surface of tonometer. It is disposable and can be removed in every patient. Now, the studies, they also say that the readings of TonoPen, they actually correlate with Goldman Applanation tonometry. So here, you need topical anesthetic drops. You have tip covers, and the area of contact is very small, and therefore it can be used in the patients with irregular cornea and corneal opacities also. Now, what are the disadvantages of TonoPen? Because although the readings are comparable with CAT, but at extremes of IOP, it is not very reliable. And moreover, CCT actually manipulates the reading of TonoPen quite a lot. And therefore, if there is abnormal corneal thickness, then we actually don't rely on TonoPen readings. There are other handheld tonometers also. Now, most important of this is the Rebound Tonometry. Now, what is this? In Rebound Tonometer, it is a very light handheld tonometer which has got a disposable probe. Very small contact area is there, and the probe that actually is kind of mechanism is of indentation only, where it springs back from the surface of cornea, and therefore it is very comfortable to be used, and we actually don't require any anesthetic eye drops also. Moreover, it has got good agreement with Goldman Applanation tonometry readings. Now, there are few disadvantages of rebound tonometry. Again, it is influenced by corneal thickness, and because the disposable probes are there, they are a bit costly also. Every time we need to change them. But because of these disposable probes, these rebound tonometer is the tonometer of choice in this era of corona infection, because we can change the probe and it doesn't actually create any micro droplets also, and therefore this is the tonometer of choice which is to be used if you require to measure intraocular pressure in this COVID era. Now coming to other newer variety of tonometers which are available nowadays. The first one is the Pascal's dynamic contour tonometer. Second one is the ocular response analyzer. And third one is the dynamic shine plug analyzer, which is Corvus ST tonometer. Now all these tonometers, they are less affected by corneal biomechanical properties, and that is the best advantage with these tonometers. So now let's see what is dynamic contour tonometry. Now here again we have a tonometer which is mounted to the slit lamp just like Applanation tonometer, but it is a tonometer which is independent of corneal rigidity and corneal thickness and is based on the principle of contour matching. So what happens is that there is a concave tonometer tip like this which matches with the corneal curvature, and because of this matching it is not least affected by corneal thickness or corneal properties. So what happens is that there is a piezoelectric sensor which measures the intraocular pressure by 100 times per second and gives you an average of these 100 readings. So it is very repeatable and reproducible. And moreover, it has been seen that it is very useful in the patients with corneal disorders after refractive surgery, after keratoplasty. But it has a little bit disadvantage that it needs a trained staff. It requires lots of patient cooperation and is time consuming also. Now coming to another very important tonometer which has come nowadays is ocular response analyzer. Now here a rapid air impulse applies force to the cornea, and there is an electrical optical system which monitors the deformation of cornea. I will just show you the video also how actually this is done. Now this device records the applanation at two events. First one, when the cornea is moving inward by the pressure jet, and then when it is coming out by the pressure jet. So corneal biomechanical response to this rapid indentation by air jet is measured, and that is known as corneal hysteresis. So it is this small video to show how this works. Now here you can see that this is the area from air where the air jet comes. This is light emitter, infrared light emitter. This is the detector, and this is the pressure transducer area. So you can see that when the infrared collimated beam is thrown onto the surface of cornea, it is non-focused at the detector level. So the air jet actually put pressures onto the surface of cornea so that it is pressed inside. And at the point where this beam on the detector becomes collimated, the reflected beam becomes collimated, this is recorded as first applanation. Now it further presses the cornea more, and then the air pump stops. So the cornea rebounds back. And the point where again the beam becomes collimated, the reflected beam becomes collimated is recorded as second applanation and is given as signal P. So there is an inward applanation, the first arrow, first graph, and the second one you can see is the outward applanation. So the difference between the two is recorded as the corneal biomechanical property, which is the corneal hysteresis. Now, nowadays it is important to learn about these factors also, because the corneal hysteresis might be coming as a short note also in your exams. So you all should know about this new thing. So as I said, ORA, it measures the dynamic bidirectional applanation tonometry. So the difference is the corneal hysteresis, and it measures the viscoelastic dampening of cornea. Now, low corneal hysteresis is associated with progression of glaucoma. And important thing is that the intraocular pressure given by this machine is already cornea compensated. So it gives a cornea compensated intraocular pressure, which is quite reliable. So what are the advantages? As I said, properties. It measures the corneal biomechanical properties and gives you cornea compensated intraocular pressure. Moreover, the values are stable at different point of daytime and it is a non-contact device. So all the advantages that it provides slightly higher and moreover it is expensive. Now coming to the latest thing, which is a novel device where there is a rotating shine flip technology which actually deformation response in 3D view exact values of intraocular pressure. So it is a very good device, gives good agreement between biomechanical corrected intraocular pressure values. It is non-contact in nature and monitors the corneal properties in vivo also and has got good repeatability and reproducibility. Now we need to check this device more and cost is the factor definitely. Now, besides these things, postgraduate student, you should be knowing something about home tonometry, which can measure the intraocular pressure by the not reliable, but you should be knowing the names of these devices. One is the DIATON tonometer, which is a measure which measures the intraocular pressure through eyelids without touching the cornea, so there is no risk of infection. It calculates the pressure by measuring the response of a free falling rod. Now here you can see that there is this DIATON tonometer, which is you can see this is the area which touches onto the eyelids and it is pressed and it automatically records and gives the reading of intraocular pressure. But the thing is that readings are not that reliable and therefore not very commonly used. Then we have another kind of tonometer which is Proview eye pressure monitor. Now here what happens is when the patient presses onto the eyelid surface, he can see pressure phosphene. And once he sees those phosphene, the recordings are automatically recorded and they are given in the digital form. Again, it has not seen a good correlation with Goldman Applanation tonometry, so not that commonly used. And there is one more, which is the Ocular S, which is handheld self-tonometry, which is applied onto the eyelids and again gives reading in the digital form. But again, because all these tonometers, they are not very reliable, so they are not advocated by any of the ophthalmologists. Now, before we move on to another issues, the very important issue which we all understand is the diurnal variation or fluctuation in intraocular pressure. And it is important to understand the diurnal variation because many of the patients, they might, the intraocular pressure might be all right when you measure them in your clinics or in your hospital. But then when you see the visual field of these patients, you might see that visual field is progressing. In that case, what we need to do? We need to measure the diurnal fluctuation of these patients. So in hospital, you can always admit the patient and measure the intraocular pressure 3 hourly, and then you can decide whether there is any fluctuation or not. But if you are in a clinic where you cannot admit the patient, then you can do split diurnal variation or office diurnal variation, where you can actually measure the intraocular pressure at different point of time, at different durations. Like once you can measure in the morning, at another point of time you can measure in the evening, at one point of time in the afternoon. Try to complete it in 2 or 3 days time, and then you can get the readings. Now the option, another option which is available for 24 IOP monitoring is this kind of contact lens, which is known as triggerfish silver contact lens device. Now here you can see this is a telemetry chip and this is the loop antenna. It actually doesn't measure the intraocular pressure but records the fluctuation in intraocular pressure in the form of graph. So it is implanted in the patient's eye for 24 hours. After 24 hours, it is connected to Bluetooth device. And then the tracings seen via those would say that pick up your purpose. What is your purpose? And then decide which tonometer to use. So if you have a very young patient, tonometer of choice is either a tonopen or a tonometer. If you have a patient where if you have series of patients coming up like CAM patients or the patients in a busy hospital where you just want to screen the patient, they are non-glaucomatous patient, you can easily use a non-contact tonometer, which is the air puff variety. And whenever you are in doubt, you can take those patients and you can confirm the readings with the help of non-contact tonometry. Now again, if you have a CAM where you need a portable device with minimal learning curve, you have tonopen or rebound tonometer. But mind you, if you have a glaucoma patient, if you want a predictable and reproducible result, the gold standard, the tonometer of choice is the Goldman Applanation tonometer. But as we are discussing that it is all affected by corneal thickness, so always perform the pachymetry, and that is why we are also itself. So in COVID era, we were talking that rebound tonometry with disposable probes are the tonometer which are to be used. So thank you so much for this presentation. And
Madam, you will be presenting pachymetry now?
yeah, shall I start now?
Just one small question.
Yeah.
You mentioned that rebound tonometry is the best option in COVID era. But
Yeah.
I think most of the postgraduates and most of the ophthalmologists in general may not be having it. So what is the next best option they have for their patient?
Now, if we don't have rebound tonometry, then we go for Applanation tonometry with full precaution. Non-contact tonometry is not advocated. As I said, micro droplets are being formed and they actually can cause infection in surrounding areas. So we avoid non-contact tonometry. So you need to take all the precaution. You need to wear your gloves. You give all precaution to the patient, and then you take a bud to elevate the eyelids. You need not to touch the eyelids at all, and that way you can do Applanation tonometry. And that way you get reliable readings also.
Okay, thank you so much. So we'll move to the next presentation.
Oh.
And then we'll take the questions. I think we'll take the questions after Dr. Jain's presentation. We have a lot of questions. We'll take it at the end.
Okay. So good evening everyone again. I'm going with another presentation which is about measurement of central corneal thickness, which is pachymetry. So we understand that pacos is the thickness and metry means measurement. So it is the measurement of corneal thickness which is pachymetry. Now it is very important because it also indicates the health of the cornea, especially the endothelial function. And this was in the ancient textbooks also. Now, this is when we see the corneal thickness in the normal eye, we do understand that the peripheral part of the cornea is actually thicker than the central part. And the central corneal thickness is 0.49 to 0.56 millimeter or in center. Now, another important thing is whenever we are having a patient who is having corneal decompensation, we understand that the cornea is thicker. And if it is more than 0.7 millimeter, that means the patient might be landing into corneal decompensation. What about pediatric eye? The pediatric corneas, they are similar to adult cornea. Only thing is that as the child is born, the infant cornea is slightly thicker but it gradually comes to a normal size of 585 microns. So what are the various techniques of measurement of corneal thickness? It can be an ultrasonic technique, it can be an optical technique, or there can be alternative measurements. So in ultrasonic technique, we have conventional ultrasonic pachymetry and we have ultrasound biomicroscopy. Whereas in optical variety, we have manual optical pachymeters, and then we have variety of other optical devices. Then in alternative measures, we have pentacam, pachycam, and ocular response analyzer. So let's see the ultrasonic pachymetry, which is the gold standard and which is broadly accepted to measure the corneal thickness in our routine patients also. Now here what happens is this instrument actually is based on the principle of transmitting ultrasonic waves onto the surface of cornea, and the rebound wave that is recorded by the transducers when it comes back from the Descemet's membrane. And then corneal thickness is calculated by the transmit time and multiplied by propagation velocity divided by 2. So the speed of sound in the cornea is taken as 1640 millimeter per second, and therefore we can calculate the corneal thickness. So this is the machine you all must have seen, pachymetry machine, ultrasonic pachymetry. So here we have this probe handle, we can see, which is of 20 megahertz. Then we have a transducer which is based inside the machine, and we have a tip over here which has the diameter of 2 millimeter only. It should not be more than 2 millimeter because you want to record the central corneal thickness in central 3 millimeter of the cornea. Well, what are the advantages of ultrasonic tonometry, pachymetry? It is fast, very simple to use. It actually is consistent and eliminates the inter-observer variation. Portable device can be moved anywhere. It is no coupling medium is required. We can simply touch the cornea, but be very careful. Don't damage the epithelium of the cornea. And because it is a mobile device, it can be used intraoperatively also. But the disadvantage is as it is a contact procedure, therefore risk of infection is always there. Moreover, accuracy is dependent on perpendicularity of probes. Placement of probe is also very, very important. You need to be in the center. So whenever you are recording, you need to check that you don't keep the probe away from the center. It is slightly lower resolution and it is not accurate for the idiomatous cornea. So we have a better device which is ultrasound biomicroscopy. Now it uses very high frequency ultrasound to produce images of anterior segment of near microscopic resolution. So you can see that these are the images which are almost similar to histopathological images. Now it was a technique which was developed by Pavlin, Sherrar and Foster in Toronto in 1980s. Now here the probe, the transducer probe, it has a velocity of 50 megahertz. It may vary depending on the make of the ultrasound biomicroscopy machine. It might range from 40 to 100 megahertz. Now, if we take a probe which is of 50 micron resolution, what happens is that as you increase the frequency of the probe, the depth decreases. So suppose you have taken a 50 micron probe, that means the depth of penetration is only 5 millimeter, and that is how you can see the anterior chamber of the eye. So this is the image of the angle of the eye, and this is the spiral spur, which is the only constant landmark seen on the UBM, and the spiral spur is actually used to calculate the quantitative and the qualitative analysis on the ultrasound biomicroscopy machine. So it has the advantage you can measure the corneal thickness very nicely, but the limitation is you require water bath, which is a coupling media, and this is actually a cumbersome method, not very comfortable for patient also, and you need to make the patient lie down. So these are certain disadvantages of this machine. But it is very, very useful in opaque cornea, because sometimes in anterior segment OCT, you might not be able to see behind the opaque cornea as the light is not penetrating nicely. But because it is based on ultrasonic machine, it is ultrasound, so it can penetrate the opaque cornea. So suppose you want to see what is inside, suppose you have a patient with a failed graft, you can see inside of the opaque cornea also with the help of ultrasound biomicroscopy. Now coming to optical devices, we had this manual optical pachymeter, now which is attached to the slit lamp. Now what happens is that it has two plano glass which splits the image of the corneal parallelepiped, and it has two methods. Now first one is the just touch technique. Here you can see in this diagram what is happening, that cornea is being divided into two, and the endothelium of the upper image should match with the epithelium of the lower image, and that way you can assess the corneal thickness. This is just touch criteria. Another criteria which is overlap method, in which you actually match the bright portion of endothelial image, but these methods are not very reproducible. It is slightly based on assumptions, and that is why manual optical pachymetry, it is not commonly used now. There is lack of accuracy, there is lack of repeatability, and requires a plan. So nowadays, manual optical pachymetry is not used. So what is used are the specular microscopy. Many of you must be seeing specular microscopy. We use this device to see the endothelial cell count. Now, in this specular microscopy, the added advantage is that you get the corneal thickness also. So advantage is that it is an operator independent machine which is non-invasive, and you can simultaneously measure the cell count also. But what are the disadvantages? You don't know the exact point where the readings of central corneal thickness is being taken. So that might actually vary in different, suppose you are measuring the same patient at different point of time, the readings might vary due to this problem. So now coming to scanning slit pachymeter, or the OpScan, which is an elevation-based system which uses scanning slit technology. So it takes multiple sections of your cornea, and not just corneal thickness, it gives you anterior elevation, posterior topography, along with anterior chamber depth. Now this device is very, very good in a way that it also measures corneal thickness, and it can give you variation in the corneal anterior and posterior corneal surface both. So it gives important thing is that it gives you 9-point pachymetry. So suppose you are going to plan lamellar keratoplasty in a patient, you want to know what is the thickness at different parts of cornea. It gives you a very nice image of all the parts of cornea. It also identifies the thinnest part of the cornea. So if you are planning a lamellar keratoplasty, you know that in which part you need to be more careful while you are dissecting the cornea. But it slightly overestimates the thickness, but otherwise it is a good machine to assess the corneal thickness and corneal topography also. Now coming to anterior segment of OCT, which is widely used nowadays for measuring the corneal thickness. It gives a color-coded map of cornea and is of very high resolution. The advantage is that it is a non-contact device. The acquisition optometrist, and it measures the thickness also. Suppose you have done suppose you have a patient of LASIK, you can measure the corneal flap thickness also, and minimal corneal opacity can also be through minimal corneal opacity. It can also be the corneal thickness can be measured. Now coming to another device, which is optical low coherence reflectometry, which is attached to the slit lamp, and sometimes you have a separate machine like this. Now it also measures corneal thickness nicely, which is based on Michelson's principle and uses a diode laser. So precision is a non-contact device, but only thing is, so you don't have any added advantage like for OpScan, you can have simultaneously topography image, or for specular, you can have simultaneous specular count also. So now coming to another device which can do the corneal thickness measurement is confocal microscopy. I'm sure you all must be familiar with confocal microscopy, at least with the name and what it does. It measures the various layers of the cornea. The precision is so high that you can see all the layers of cornea, and not just this, it actually can identify the various scars. Suppose you have a patient with corneal dystrophy, what are the various levels of opacification it can identify. It can also give you endothelial cell count, and not just this, it can also identify the various types of organisms in the cornea with the kind of infection it can identify. So that way, confocal microscopy is a very good device, but yes, definitely it needs lots of precision on the part of examiner this test about this, that it can look the location of the opacity, the corneal thickness also. Although some poor agreement has been there with ultrasonic pachymetry, but precision is good. Now coming to a novel device and a very accurate one also, which is the pentacam. It is again based you a 3D image of whole of the cornea and so it gives you corneal topography, it gives you pachymetry also along with 3D analyzer. So it is a comprehensive eye scanner which is very useful for a variety of situations along with corneal thickness measurement. It is a non-invasive and non-contact device. Important thing is that even the minutest of the eye movement, they are captured very nicely and then they are corrected simultaneously to give you a perfect image. So precision of the device is very, very good. It has got variety of applications like in preoperative planning for corneal refractive surgery, for glaucoma screening. You can modify the intraocular pressures results along with corneal thickness, and then also in keratoconus detection. Now this is another device which is PachyCam, which is just like a pentacam measuring only corneal thickness, and it gives you a 3D alignment screen. It is a non-contact device and lightweight, which is known as PachyCam. Now again coming to ocular response analyzer, we actually discussed it in the tonometry section also, where it measures the intraocular pressure and gave you cornea compensated intraocular pressure. Again, ocular response analyzer is a device which measures the biomechanical properties of cornea to a rapid air impulse. I showed you the video also in tonometry section. So besides corneal thickness, the corneal biomechanics is another important topic which you all can get as a short note in your exams. So what is corneal biomechanics? Actually the cornea exhibits elastic and viscous properties both. So any viscoelastic material which exhibits both kind of property causes energy dissipation when any stress is applied, and that is corneal hysteresis. We already discussed about this, so I am skipping this part. Now the difference between the inward applanation and outward applanation is the corneal hysteresis. Another factor which is measured by the ocular response analyzer is the elastic property of the cornea, which is the cornea resistance factor, which is ability or the cornea to deform and then to again come back to its original position. And it appears an indicator of corneal resistance, that is K. Now this is measured by ocular response analyzer. So this we already discussed this graph. So now what are the clinical implications of corneal hysteresis? It is highest in the cases of ocular hypertension, and we have higher corneal hysteresis in the patients it is protective. If you have a patient who has higher corneal hysteresis, it is kind of protective, same as type of central corneal thickness. Lower corneal hysteresis is associated with greater loss of RNFL. Now, various studies, they have suggested that corneal hysteresis is negatively correlated with cup-disc ratio and increasing age. And the patient who have higher corneal hysteresis, the drop in intraocular pressure is less on adding the medication. So suppose you have a patient whose pressure is 26 and you want to add another medication and the pressure is not dropping down, you can check his hysteresis and it might be on the higher side. So again, coming back to corneal thickness, it has got role in glaucoma. We all have understood that, but it is also important in certain of the corneal disorders, like for planning of a patient of LASIK. If you have a keratoconic patient, to monitor the treatment response in corneal decompensation. If you serially measure the corneal thickness and if it is decreasing, you know that your treatment is on the right line. Then for lamellar keratoplasty surgery, we already discussed. Now coming to role or implications of central corneal thickness in the patients of glaucoma. So we have understood that corneal thickness is a significant predictor of development of glaucoma and it aids in glaucoma management. In congenital glaucoma also, we need to assess the corneal thickness to assess the amount of corneal edema and then serial follow-up of the patients of corneal decompensation. So the OAT study, the ocular hypertension treatment study, it said that thin corneas are the risk factors for conversion of ocular hypertension to primary open-angle glaucoma. So the patients who are having corneal thickness of less than 550 microns, it was seen that the risk of progression to glaucoma is almost 3 times. So you need to be very, very careful in the patients who are having thinner cornea. We also need to be cautious in few of the patients which are having thin corneas, or the elasticity or rigidity is very high, or their curvature is very steep or curved, because the accurate reading of IOP might not be there in such patients. Besides this, increased central corneal thickness is found in the patients of ocular hypertension. Decreased central corneal thickness is found in the patients of low tension glaucoma, and that is why the patients who are having higher corneal thickness, they are likely to be less progressing than the patients who are having lesser corneal thickness. Then the patients who are having pseudoexfoliation syndrome, corneal thickness have found to be lower in such patients, has been found in the individuals with pigmentary glaucoma and primary angle closure glaucoma. So how can we make most of our Goldman tonometer? By incorporating the central corneal thickness in our patient. So what precautions? Now this is almost my final slide, that what precautions we should take in patients in whom we are going to measure the central corneal thickness, so that whenever we incorporate our central corneal thickness to Goldman reading, we get an accurate idea of intraocular pressure. So first and foremost thing is, there is no clear-cut algorithm to say that how much correction we should put to get accurate IOP reading. So there are a variety of studies coming up, there are a variety of algorithms are coming up, that we can compensate for 50 microns of cornea to 3 millimeters of intraocular pressure. But to be very frank, as such, there is no standard defined as of now. So what to do? So you can divide your patient into 3 categories. Simply note that whether the patient is having thinner cornea, he is having a normal corneal thickness, or is he having a thicker cornea, so that you know that how frequently, how diligently you need to follow these patients. The third important point is that whenever you're going to measure central corneal thickness, once you have anesthetized your patient, ask either do the corneal thickness immediately, or if suppose you are getting delayed due to some response, patient to blink frequently, because if the cornea dries up, the corneal thickness becomes lesser. So you don't want this to happen. Then suppose you have to perform your gonioscopy, first do corneal thickness and then perform your gonioscopy, otherwise the readings might vary. And this point I already mentioned, that always measure the corneal thickness in center 3 millimeter diameter of the area to get your accurate reading. And once your corneal thickness is less than 500 micron, you need to be extra careful with that subset of patients. And if the corneal thickness is more than 600 micron, probably your patient is in less danger zone. Thank you so much for your kind attention.
Thank you, Dr. Shalini. So I think we'll be moving ahead with the next presentation by Dr. Vikram Jain, who is the director of Prasad Netralaya, Mangalore, and has been previously an assistant professor at Kasturba Medical College. Dr. Jain will be speaking about target intraocular pressure. Most of the questions which have been asked in the chat group has already been discussed by Dr. Shalini. But there's one question I'd like to ask Dr. Shalini. Madam, there's a question that about ocular rigidity. Why Schiotz tonometer is more dependent on ocular rigidity compared to Applanation tonometer?
Now, already I showed in the animation that whenever there is indentation, the corneal deformation is much more than an applanation. So due to corneal deformation, large amount of aqueous is displayed. So once large amount of aqueous is displayed and the globe is compressed quite a lot, in fact, it is indented. So that is why it is more dependent on ocular rigidity, which is not happening with the Applanation tonometry.
Thank you. So we'll take any further questions after Dr. Vikram Jain's presentation. So Dr. Vikram.
Yeah, thank you, Dr. Maneesh Singh. Thank you, Dr. Maneesh, Dr. Satyajit and Dr. Pooja Sinha for having me in this program. I'm just trying to share my screen. Yeah, is my screen visible now?
No.
Not yet. Not yet.
Not yet.
Not yet.
There's a share screen below.
Yes, yes, yes.
You'll have to open your PowerPoint, minimize it, and then.
Yes, just a minute. I'm trying to do it. Zoom will not be able to record content.
You can take a few questions until then, Maneesh.
Dr. Shalini, one more question I wanted to ask you about the more commonly one pachymeters which we have actually is the ultrasonic and the optical pachymeter. So among these two, if a clinic is having both optical and the ultrasonic, which one you think should be the preferred option?
In fact, there is a very recent study on that, and they say that ultrasonic is more reliable than optical pachymeter. And because in optical pachymeter, you actually use the calipers to measure the device, and ultrasonic, it gives you automatically. So there was a recent article I was reading, and ultrasonic is more reliable than the optical one.
So, and one more question, what is the type of tonometer best for post-penetrating keratoplasty patients?
Yeah, as I discussed, the MACKAY type of tonometers are best for keratoplasty patient. And the one which is commonly available to us is the TonoPen. And in fact, the Rebound Tonometer is also reliable in that case. You can use any of the two because the area touched by the rebound is also very less. And by TonoPen, it is obviously based on MACKAY type of tonometer. So any of the two which you are having can be easily used for keratoplasty patients.
And there's one more question we could take. I think Dr. Jain is already ready. What is the highest intraocular pressure you can check with Applanation tonometry?
So if you go beyond 6 is that means 60 you can measure, and beyond 6 you can it is 70. So 69, 70 you can measure on a Goldman Applanation tonometer.
Oh, thank you, Dr. Vikram.
Thank you.
Yeah, Dr. Vikram, we can see your slides.
Yeah. So I think I'll go ahead. The topic for me is the target intraocular pressure. I might need a little help. My slides are not advancing, Dr. Maneesh. Any idea how to go about that?
You can go to the lower left portion of your screen.
Okay.
There is a button where you can advance the slide. After that, you can use the switch of your laptop. The first time, I think you have to use, go to the lower left side of your screen.
Okay.
This is the button to advance the slide. Next slide and previous slide, that button is there.
Pause share remote control. No.
Yeah. Now we can see. Slides have changed.
Okay. I'll just try it once. Sorry about this.
There's a lag between his changing and showing over here.
It did not forward for some reason.
Okay.
Is it changing now?
Yeah, it's changing now.
Perfect.
Okay, fine. So as Dr. Shalini has already mentioned about everything about intraocular pressure, and the most important factor also she mentioned that intraocular pressure is the only modifiable risk factor for glaucoma. Glaucoma, primary open angle glaucoma we are talking about, might have many risk factors in which IOP is the only one where we can modify, and it is the only established method of treating glaucoma. And therefore, this concept of target intraocular pressure, what intraocular pressure should we as physicians choose for a given patient, is very important. So here you have retinal ganglion cells which are lost in glaucoma versus age. If you see the small gray graph on top, that is the normal slow loss of retinal ganglion cells, whereas the red graph is a patient with glaucoma who is untreated. With treatment, you're trying to modify this downward curve to make sure that it does not touch the baseline, that is loss of most ganglion cells, so that the patient has good vision through his or her lifetime. So this is the basic that we are going to be keeping in our mind while treating patients, that patient should have useful vision throughout their lifetime. This is what we are trying to achieve by putting them on medications or doing a surgery, is by decreasing intraocular pressure. We are going to be decreasing the rate at which retinal ganglion cells are lost. Now, this particular hypothesis, that is decreasing intraocular pressure is useful in treatment of primary open angle glaucoma, has been proven in many trials, the most salient of which are the EMGT, early manifest glaucoma trial, AGIS, that is the advanced glaucoma intervention study, also in the CNTGS and OHTS. In the EMGT, it was shown that if untreated, more than 62% of the patients do progress, whereas if they are treated, only lesser than 45 patients progress. If we look at the criteria, it is an early glaucoma and only a moderate reduction of pressure was done. Therefore, only there was still progression in 45% of the patients. Advanced glaucoma intervention study showed that whenever there is a lower intraocular pressure as well as lower intraocular pressure fluctuation, the progression is reduced to a drastic extent. And consistently low intraocular pressure reduces loss of visual field. In the collaborative normal tension glaucoma study, we had two arms, that is the untreated and the treated arm. In the untreated arm, there was 60% progression, whereas in the treated arm, only 20% of the patients progress. So all these studies, and one more is the ocular hypertension treatment study. All these studies just prove that lowering intraocular pressure is a definitive treatment for glaucoma. Now, how much to lower? These also suggested some guidelines. In the ocular hypertension study, a 20% lowering of intraocular pressure was advocated, and 30% was advocated in the normal tension glaucoma study. Now, these epidemiological trials cannot be the only basis to set a target intraocular pressure. A small example I've given on your screen. For example, if a patient comes with an intraocular pressure, asymptomatic patient, walk-in patient with an intraocular pressure of more than 40 millimeters of mercury, 20% as advocated in the OHT would mean that his pressure would come down to 32 millimeters of mercury. Whereas in a NTG guideline, that is 30% reduction, it would be 28 millimeters of mercury. We all know that our epidemiologic data has suggested that the normal range of glaucoma in a normal population would be between 10 to 21. And whenever the pressure is more than 21, definitely there is going to be a scope for visual field progression or a new defect in case there is no defect. Therefore, these epidemiologic data of 20% or 30% are just rough guidelines, and we cannot use only these to set a target intraocular pressure. Also, target intraocular pressure should be chosen on an individual basis, weighing all the benefits and risks of treating in each patient. To define a target intraocular pressure, it would be the upper limit of intraocular pressure that would prevent any further glaucomatous damage in that particular patient. So when do you set a target intraocular pressure? In the first visit itself, once you establish that yes, this is indeed glaucoma, then you should set a target intraocular pressure, and periodically, maybe once in 6 months, you have to go back to it and revise it and see whether the target pressure that you have set is okay or whether it needs a further revision. A few formulae were also suggested, something like this, where IP is the initial pressure and Z was a variable given for if the patient is a glaucoma suspect or an end-stage glaucoma patient. Again, these formulae do not take into consideration many individual characteristics that the patient can have. So as I mentioned earlier, how much to lower, that is the target pressure, has to be individualized. So the factors that we should take into consideration, three main factors, is the initial intraocular pressure, that is the pressure at which they are first diagnosing, the pressure at which damage has been documented, life expectation of the patient, and pre-existing damage at the time of diagnosis. How much of damage does the patient already have? How much of damage, meaning both ocular nerve head damage as well as damage seen on visual field, that is the loss of visual field. Other factors like rate of progression is also important, and other factors on an individual basis are presence of severe damage in the other eye, family history of loss of vision due to glaucoma, high myopia, and other vascular factors. So in case the IOP at diagnosis is high, then the target IOP that we set can be a little on the higher side. That means that his or her optic nerve has withstood severe intraocular pressure. Even if the target is set at a higher level, it can withstand some amount of damage. Whereas if it is a low intraocular pressure to begin with, that means the overall threshold of that particular patient's optic nerve head is low, and the target has to be set at a lower level. Again, coming to life expectancy, if it's in a young patient who's likely to have a very long life expectancy, there is more time for which damage can occur. Therefore, the target intraocular pressure should be set at a much lower level. Whereas if it is a fairly elderly patient, let's say 75 at diagnosis, and life expectancy may be 10 years more, then you can set a moderately higher target intraocular pressure, because the time for damage remaining may not be much long, as in when compared to a patient who's 40 years and who has a horizon of another 40 years in his lifespan. If the damage to begin with in the optic nerve head or the visual field is very early, again we can set a higher target intraocular pressure when compared to advanced damage on visual field or optic nerve head. So stage each eye for the glaucomatous damage. This is a guideline with taking consideration with the visual field printout. Early glaucomatous damage would mean that the mean deviation is lesser than 6 decibels on a rough this one. Moderate would be between 6 to 12, and an advanced would be more than 12 decibels on mean deviation. You should also look at the central points and see whether in the central 10 degrees, if there is something very close to fixation, then you would revise it upwards as given in these guidelines. The European Glaucoma Society had proposed overall guidelines for mild glaucoma, the target intraocular pressure to be set below 18, whereas for a severe glaucoma to be set below 12. One nice thing about this intraocular pressure below 12 is that once the pressures reach this particular point, that is 12, 11 or 10, there is very little progression seen from that point onwards. That is intraocular pressure dependent progression. Similarly, American Academy AAO has given guidelines. Again, if you see the bottom two, advanced glaucoma, the target intraocular pressure always has to be below 15. I would further revise it for advanced glaucoma and say keep it below 13. And if you see the OHC guidelines, wherein the intraocular pressure, the bottom most of more than 30 millimeters of mercury with no signs of optic nerve damage, our target of the intraocular pressure should be around 20 when the fields are normal. Again, to repeat it, individual target pressures for individual eyes. Now, if these are two eyes of the same individual, each eye has got a different level of damage, and therefore each eye would have a different target intraocular pressure. Now, this is something you should remember very well. Do not give a blanket target intraocular pressure for a particular patient. Each eye would have a different target intraocular pressure. Look at other factors like presence of severe damage in one eye or vision loss in a family member due to glaucoma. Now, these would mean that this patient would have, you can expect a more aggressive course and therefore revise it further lower. High myopia is a separate risk factor. Again, you would revise it lower. If the patient has got a RVO in the other eye, again, that would mean that this particular level of control of intraocular pressure is not enough. It can lead to an RVO in this eye also. Therefore, you would revise it further lower. So treat each eye differently, each patient differently. Look into the other systemic factors also. Initial slide, I mentioned two other factors. One was rate of progression and existing damage. In the existing damage already, while showing you that particular classification, I told you that look at the central 10 degrees. Now this slide would show you this particular patient. If you look at the foveal point, one of the points is 0. That means that his fixation is threatened. Such patients, again, you would like to keep them at bare minimum of pressure of below 13. Again, to zoom into this field, if you see on one particular side at the fovea, the absolute value is lesser than 0. That means that the fovea has been threatened. The damage is quite severe right at the center. This patient can have a sudden loss of vision if the remaining foveal points are also involved. So in this particular case, you would further revise it lower. You would also look at the rate of progression, which would be different in each patient. Everybody would progress. Whether the patient is on treatment or not, they would progress. In example E, if you see here, it's a very rapid progression. Example C also is a fairly rapid progression, which can lead to either blindness or decrease in quality of life. Now, I'll come to this in a further example. This particular graph can also be got from our perimeter. This is known as guided progression analysis. The perimeter can give this GPA printout wherein visual field index is plotted against the patient's age and extrapolation is done for the next few years. To simplify it further, this is known as the VFI regression plot, which would then give a projected future loss also. If you see on our left side, the VFI is graded between 0 to 100 degrees and lesser than 30% would mean that severe quality of life is affected. When it falls below 30 degrees, you should try not to let your patient progress beyond that. Therefore, always try to get this printout in your visual field so that you know where you stand, how fast the patient is progressing. If it is a rapidly progressing patient, further revise the target intraocular pressure to a much lower level. To give an example, this particular patient has a scotoma as shown in this field. Now, if this were to be a daily life scenario, you would see that that particular area, there is actually a scotoma. This patient would then think of the building being complete, the road being complete, and totally miss whatever is there. That is why when we talk about quality of life, as soon as it falls below 30, this is how it is affected in our patients. So make sure that the rate of progression is slow. In this particular example, if you see over the next 3 years, the VFI would touch 0% if the target intraocular pressure is not changed. If you continue the pressure on the same patient on the same medications at the same level, you would have a false notion that the target intraocular pressure is okay for this patient. It is enough for it to be, let's say, 16, since his fields are okay. There's only for example, a mean deviation loss of around 11. But then if you see the rate of progression, it's a rapidly progressing field. You should keep this also in mind and revise it further to decrease the target of target intraocular pressure further lower. So whether target IOP is achieved or not, you would not know unless you analyze the patient's visual field in progression and make sure that there is no progression. Always revise it every 6 months. It can be confirmed only with time. Monitor for progression. Keep looking at the patient every 6 months, both optic nerve head, either with OCT or with visual fields, and reevaluate it periodically because the patient might develop a new systemic or ocular condition that might affect therapy. Despite lowering intraocular pressure, some eyes would continue to progress. These are non-IOP dependent factors which are beyond our control. The only factor that we can control it in all our patients is intraocular pressure. And when I talk about target intraocular pressure, I mean corrected intraocular pressure. Already Dr. Shalini has so wonderfully discussed pachymetry and correction of intraocular pressure. As madam has said, classify it into thin corneas. If it is thin, always keep it at the back of your mind that further our intraocular pressure has to be reduced further. So reassess your target, stage each eye independently, and look closely for progression. That would be the take-home message for my talk. Thank you.
Thank you, Dr. Vikram. I think it was a very lucid presentation. You very nicely discussed all the important concepts of target intraocular pressure related to calculation. And so till now, we don't have any questions related to target intraocular pressure.
Sure, I'll be on the line.
Just, I have one question related to this. So suppose you were discussing about ocular hypertension.
Yes.
You have a patient whose pressure is around, say, 29 and 30 millimeter mercury. The angles are open, disc is healthy. It's a patient with a clear-cut case of ocular hypertension with a family history of glaucoma also. And you want to bring down the pressure. So how much IOP reduction you will aim and what drug you will consider to reach your target intraocular pressure?
Now, in ocular hypertension, unless the pressure is more than 24 to 26 millimeters of mercury, we can closely observe the patient. As you mentioned, it is about 26 millimeters of mercury.
About 29, 30.
Yes. Plus, one more factor that you mentioned is strong family history is there. So definitely this particular example needs to be treated to get the pressure below at least 24 millimeters of mercury. This can be achieved with a single drug, either timolol or latanoprost. Since you asked me how I would go on treating the patient, advantage of latanoprost is good diurnal control as well as good reduction in the intraocular pressure. If cost is a limiting factor, I would put the patient on timolol.
Okay. So suppose you have started a patient on prostaglandin or maybe timolol and the pressure has come down to 22 or 23. Will you further try to bring down the pressure or will just keep under observation?
We would observe the patient by doing a repeated visual field analysis. And unless the patient develops a field defect, I think we could continue the patient to be on this single drug regimen with the IOP being around 22, the corrected IOP if it's around 22, that should suffice. Dr. Shalini, is there anything else that you want to
add to this?
I think I will congratulate Dr. Jain for his wonderful presentation, and he has nicely answered this question, and I think I agree to what he said.
There is one question for you, Dr. Shalini, that why intraocular pressure is overestimated in high CCT and underestimated in corneal edema?
So actually, you know, it is not the actual reading. It is a fallacy. So when the normal Goldman Applanation tonometer is fixed to measure the accurate IOP at 540 microns. So thicker. So the prism when touches the cornea gives more resistance, and that is why it is the recorded reading is more in thicker cornea. But in corneal edema, what happens is that because of the fluid in between the different layers of the stroma, this gives an underestimation of IOP despite the corneal thickness being more. So that is why because of the interlaminar fluid, the recordings we get is lesser in corneal edema.
Thank you. I think we'll have probably one more question. Which is better, OCT or fields or IOP? What combination is best for follow-up? So, Dr. Vikram, will you answer this?
Yes. IOP has to be measured at every single visit. If your patient is documented to be non-progressing, then you can do fields once in 6 months. If you're still establishing a baseline of fields, I would do fields every 3 months until I see that the patient is non-progressing. And after that, do fields every 6 months. OCT, we still do not treat based on OCT changes or OCT findings, but that is complementary to visual fields.
Thank you. And before we go to the last question, I think just small announcement that tomorrow again at 5 p.m. we will be meeting for our third webinar. There are 2 presentations tomorrow. First is on gonioscopy, followed by another presentation on angle imaging, that is the entry segment OCT and the UBM. And I think there's a last question which Dr. Shalini can take. What is, like, at what pressure will you call it to be a hypotony?
So I think now the normal intraocular pressure we know is 11 to 21 millimeters of mercury. So normally whenever pressure is less than 6 millimeters of mercury, we take it as hypotony. And into it?
I think we're not able to hear you, madam. Can you just, so less than 6 millimeters is hypotony. Yeah.
Yes.
So I think we don't have any other questions. So I'd like to thank both Dr. Shalini and Dr. Vikram, and I'll hand over this to Dr. Satyajit Sinha.
Thank you so much, Dr. Maneesh, for moderating it so well. I'm very, very deeply indebted to Dr. Shalini and Dr. Vikram Jain for taking out time and making such a wonderful presentation. My entire glaucoma session was revised with Dr. Shalini's presentation, and Dr. Vikram's presentation was also very wonderful. Tomorrow we have Dr. Reena Chaudhary, who will be speaking on gonioscopy, and these talks are specially tailored for postgraduates in such a manner that you will realize that the speaker is not rushing through the slides and trying to explain you as much as possible, though we are not there in person, whatever best can be done on the webinar. And you are also free to ask questions. Both the presentations were wonderful. And the next presentation tomorrow is by Dr. Prashant, who is talking on anterior segment OCT, which is also another major question now in post-graduation. Once again, I would like to thank everybody, all the postgraduates. We had over 100 postgraduates from all over India today. And whoever wants a copy of this presentation can write to me at EYE, that is EYE Sinha@gmail.com. So my name is Dr. Satyajit Sinha, and you can write to me at EYE Sinha@gmail.com, and I will send you the link, Zoom sends me a video link of all this recording about 2 to 3 hours later, and late in the night or tomorrow morning, I can send you those YouTube links. We have the whole of ophthalmology lined up for the entire month and beyond. So we look forward to seeing you every day here from 5 to 6:30 p.m. Thank you so much to everybody for being with us today. Thank you so much.
Thank you so much.
Thank you, Dr. Satyajit, and congratulations for this wonderful program. I just saw the flyer yesterday. There's literally the who's who of glaucoma in your program. Thanks for including me too.
Thank you so much for including me too, Dr. Satyajit and Dr. Maneesh. It was wonderful to have this presentation.
I have both of you, and very rightly mentioned by Dr. Satyajit. We also have learned so many new things about IOP assessment, and even target intraocular pressure presentation was very lucid. I think so it must be very useful for PGs because they do get a long question on target intraocular pressure.
Yeah, very nice presentation. Thank you so much. Thank you, everyone.
Thank you, Maneesh.
Thank you so much.